Hey everyone, happy Sunday to you. I hope all is well. I'm actually doing this on Saturday, but I'll release it Sunday. So happy Sunday. Again, I hope all is well and you're cruising right along. Most of you are doing phenomenal in here. Couple quick notes. I did release extra credit in the announcements for you to look at. It's now listed in D2L as well. If you want to do extra credit, just note I won't take it for zeros. It's only to bring grades up that you didn't get what you want. And just really FYI, if you're only going to do one, I mean, you don't have to do any, that's totally up to you. But if you're only going to do one, I would choose number 4 because it's a list you'll use throughout your career. You will always update your list. I keep a running list of referrals. And that's all it is make a referral list. Anyway, you can look at the instructions. If you have any questions on any of the instructions, don't hesitate to reach out to me. Also, real quick, a side note here with the APA. Many of you, I commented in your papers or whatnot, or even in your DB, some of you, that anytime you have more than one author, you only list the first author followed by et al. Et space al period comma. That's how that looks, right? Or actually, it's period then comma, I think. Either way, you can get you can look in the APA tab and see. But it's et al. That means more than one. So just be sure to keep that in mind moving forward. So I've got a few notes here. This might be a little longer video. I wanted to wrap up Smart Recovery and make a quick comparison and then kind of look ahead as well as to what's coming up. So as many of you experienced with Smart Recovery, some of you loved it, some of you less than loved it. Either way, that's okay. I'm glad you all were able to experience it because, again, I've said many times throughout the semester, as LCDCs, it's our ethical responsibility to know about these programs, know how they work, know the logistics of them, the philosophies, so that we can educate our clients so that they can make a more informed decision of what may work for them. And we can have all the ideas in the world of what works for them, but it's what they think is going to work for them that matters. Now, sure, we're going to guide and we're going to educate and do those things, but we want to steer clear of influencing their decision. So that said, many of you, well, it was a split here in some way, like probably a 60-40, 70-30 maybe, of some of you saying you couldn't. You had trouble finding a meeting, and I found that I don't know. I found that crazy kind of because they're all over the place. Maybe it was just the search you looked. I don't know, but most of you said how easy it was. So maybe it's just the search criteria. You know, when you expand that for obviously much further distances, there's all kinds of online meetings. So that said, you know, many of you noted the lack of in-person meetings, and yeah, there's not very many in the greater Houston area. Yeah, you know, I don't know why that is, honestly. I love Smart Recovery. I love 12-step work. But it's Smart Recovery from a clinician's perspective. I don't know how a clinician wouldn't like it because it's cognitive behavioral therapy in some way, right? It's not cognitive behavioral therapy, but they're using their ideals and philosophies there. So, you know, on one hand, you have 12-step work, which believes in, you know, the fellowship, the community aspect of sobriety. And I'll tell you on a personal note, that was very important to me in early sobriety, having that community. SMART doesn't operate that way. By their very name, their acronym stands for self-management and recovery training, meaning they believe you can do this work on your own without the fellowship. And given the work it is, I agree. And I think there's value in that, and the two can really work together, honestly. I'm gonna talk a little bit more about how that looks. So the self-management aspect versus the community aspect is a very different philosophy. And I'm going to say this probably many times throughout this video, is many of my 12-step folks who come in sober through or clean or whatever adjective there or descriptive word you'd like to use is they struggle with that a little bit, right? We need this higher power to lean on. We need this fellowship. I couldn't agree more. Like, I think it works great for most people, but from a personal perspective, from a clinical perspective, you know, both work. And it's what my what my client wants and what my client feels is the best fit for them. And I want to remind you all that don't let your personal opinions get in the way of your clinical knowledge and what you're trying to do clinically to help somebody, because there's not really a place for personal opinion. Yes, our experiences have great value, great value, yet they're irrelevant at the same time. And I know that's a struggle for some of you. Again, I commented in many of your papers were programmed, pun intended, to view recovery a certain way, right? Because, the reality is Alcoholics Anonymous started this movement in the 30s, and it's the foundational piece of what most treatment centers use, and it's solid principles, I believe. But again, it's not for everybody. But they're very rigid in their process, and if you got sober in a 12-step program or became abstinent in a 12-step program, most of you are very passionate about that. I get it. And we're taught nothing helps someone like one, quote, alcoholic or addict, and you know how I feel about that language. We'll get into that a little more as well in this video. There's nothing like one alcoholic helping another. And I'm just going to stick with alcoholic. When I say that, I'm referring to, quote, addict, NA, AA. I'm just going to say AA. I'm referring to all the 12-step work, CA, CMA, all of it, right? I don't want to have to keep running down. Alcoholic, addict, you get the idea. But I think that has great value in that setting. Remember, this is not treatment, it's not clinical. Although there's some similarities and ideals, it's very different. And in a self-help group, yeah, it's appropriate. Like, use that. It is Alcoholics Anonymous. Use that language. I would never roll into an AA meeting and say, well, you can't call me an alcoholic. That's their norm. That's what they do. And in that support group setting, there's great value in that, right? Great value, actually. And there is great value in one person helping another with the same or similar experience, 100%. There's no denying that. That's why I send families to family groups. That's why I send clients to support groups. In that setting, keep that in mind, that phrase. Yes, many people make positive changes without treatment, without counseling, with just one of these support groups. I did, personally, 16 years ago, right? Like, it changed my life, just these groups. I couldn't afford counseling and wouldn't have probably gone anyway, and definitely didn't know anything about treatment at the time, right? So, yeah, that happens too. There's still not treatment. There's still not clinical care. There's still self-help groups, right? Mutual aid groups, call them what you want. Support groups in some way. So yeah, keep that in mind. And like I use the example of a brain surgeon here, right? Like, if I'm going to have brain surgery, my physician, my surgeon, doesn't have to have had brain surgery himself to help me. He or she has to be skilled at what they do. They have to have knowledge at what they do, right? And they have to be competent in what they do. They don't have to have had brain surgery themselves. However, if I go to a brain surgery support group, you bet people in that group better have had brain surgery, right? Because that's why I'm going for that support. So the two work hand in hand, and this is very much like counseling, right? And I'll be honest with you, a lot of the counseling I do is navigating 12-step work with people, right? So it's not that I do or don't like it. I think the principles are solid as a rock, right? Be a good human, control what I can control, practice acceptance on the things I can't, live in the moment, live in gratitude, help others. It's a pretty solid philosophy of living, right? As you know, the labels, that SMART doesn't do that, or 12-step work does. I'm Dan, I'm an alcoholic. Now, again, in that program, that becomes a badge of honor almost. Like, I'm Dan, I'm a grateful alcoholic. And I never understood that at first, right? And I believe over the years, so quickly, just let me stop here for a second before I revisit this. When I'm talking about this is just from personal experience, some professional experience, but I tried this program 20 plus years ago. I stayed sober a year and a half, 13 months to be exact, not a year and a half. And I didn't do any work. I just went to a ton of meetings, right? Felt good. And then returned to use, and I was in and out for 3.5 years until I sobered up 16 plus, a little over 16 years ago, right? And I went for 2 years then, and then I never went back. But I still live by those principles, right? And I tell you that to say this: my understanding of the labels is just from my experience. I'm not talking about research information. I just want to be clear on that, right? But I believe when they say I'm a grateful alcoholic, the ideal is that, I was living this lifestyle. I found this program. It changed my life to give me the life I have today. Therefore, I'm grateful for that. Yeah, no, I get that 100%, right? But I've also heard it said that, you got to remember, that's why we're saying I don't need to be called an alcoholic to remember 25 years of misery, right? Just on a personal note. Yes, I don't think we forget. I think we rationalize why it's okay to do these things moving forward, right? It's not that I forget. It's that, I rationalize why it's okay. So anyways, that's SMART doesn't do the labels. SMART, where AA has a singleness of purpose, a desire to stop drinking to attend our program. That is their focus. I mean, the title's Alcoholics Anonymous, right? So that's understandable. SMART is about many things, process addictions, anything, because it's cognitive behavioral therapy. People say, again, we're programmed to look at this a certain way. Well, I have to work with people that are just like me. Well, I would challenge that too. Again, I think there's great value in that. But I would also say, if we look past the events or the substance, then we get to the feelings that are driving that behavior. That's where we do some work as clinicians. And I think that's where we can learn to relate on a different level. If we get out of the mindset that I got to have one alcoholic to another or one addict to another, well, that's good. That's got its place for sure. But also, I can look past that and see what's driving that behavior, right? What feelings? That's where we get to the work in counseling, right? Is the feeling piece. I had a client one time tell me, Dan, I tried to go to one, he was, to clarify, he was a straight up drinker. And he's like, Dan, I've never been to, I tried to go to one of those NA meetings, he said. He's like, I just couldn't relate. I've never been to a drug den before. Now, I kind of chuckled. I'm like, bro, nobody's been to a drug den since like 1978. That's not really what they call it today, but I get it, right? He's like, well, I've never lived that lifestyle. I said, yeah, no, your lifestyles are completely different. And so I can understand on the surface why you may say, oh, I can't relate to that. I also understand why there's value in living that same lifestyle and connecting on that level too. But if we look past the lifestyles and what's driving those behaviors, I would bet an arm almost that they're very similar, right? And on that level, we can relate, and that's where we get some work done. So I think it's good to have a mix of folks at times too. One of you wrote in your DBs that it was a quote from the book, I believe, or maybe it was the SMART website. I forgot to note that, but one of you wrote, counselors have biases that make them, biases, I don't know I never know that one, right? Anyways, counselors have biases that make them favor certain programs, and I've found that in my career of 15 plus years to be 100% true, right? Again, most of our treatment centers are 12-step based, so of course they're going to have 12-step people. And 12-step people, I am a 12-step people, right? Like I am a 12-step person. I love it. But they're very rigid in their thoughts a lot of times. And they're very, very much, rarely have we seen a person fail that's thoroughly followed this path. So if you're failing, quote, then that means you're not doing something, which it's not fair to put on a client that way. All that said, I'm not saying it's wrong. I'm just saying, clinically speaking, we need to really watch how we approach that there. But I think that's true. All of us have biases. I used to teach a multicultural class, and I love that course. It's probably one of my favorite courses I've ever taught, because of course I get grief for being a 50-year-old white male teaching a multicultural class, right? And that shows a bias on its own, because isn't this a culture too? Right? That's how easy it is to have these biases, right? Like it's I love the course, man. It was such a good course. It really taught us all about some of our own biases we have. So it's real important we don't let that get in the way. And like I mentioned, we don't let our personal opinions get in the way of what we're trying to do clinically. I can love AA. Or I can hate it either way. My client can love or hate it. It doesn't affect what I'm trying to do with them. right? Because again, it's about them. I'm here to walk with them through their choices, not choose for them. So the other difference in the two programs is the disease versus choice models, right? A lot of professional research supports the disease model, the medical model, right? I'll tell you on a personal note, I'll take that to my grave. That's a thing. If you've ever experienced it, for those that have an SUD, if you've ever experienced that, what AA's called in the 30s, the mental obsession, there's nothing like it. I can't, if you haven't, I don't know that I could accurately put it into words and make it make sense and do it justice. It's literally insane, right? And I feel like that's out of my control. And so here's how I do it here's how I explain it in a very simple format is, I feel like we all have these internal switches. People without a substance use disorder can drink or do drugs or whatever it is, and when they get to this point, they can flick that switch and say, I'm good. I got to stop. I'm getting tipsy. I'm getting buzzed. Yes, do they tie one on occasionally? Sure. That kind of thing. But overall, they can stop that. Me, I have a double on switch, right? Like I literally, when I should be shutting down, I'm double fisting. And I'll tell you in the moment, that's what I want to do. That's not what I want to do ever. And I know it's no good while I'm doing it. And I literally cannot control that. That has hijacked my brain. My brain's reward center saying, I need this. I have to have this way. And so for that reason, I'll take that to my grave. The disease models, the disease concept, the medical model is 100% accurate. That said, the choice model is got some merit as well. And many of us don't like to think that, but yeah, it absolutely does. Because think of this, recovery. Let's put recovery aside. Life stuff is just series of choices. There is not one pill, one shot, one psychiatrist, one therapist, one counselor, one treatment, one meeting, one group that fixes all of this. It's a combination of all of these things, and it's a culmination of choices made in each one of those things consistently, daily, thousands of times daily sometimes, right? Like it's a constant series of choices. So if I come to a T in the road and drinking to the right, nothing to the left, is that a choice or a disease that makes me turn? I think that's a choice. That being said, one could argue, and rightfully so, if I have this disease that's hijacked my brain, isn't it guiding my choices? Yeah, that's fair. That's absolutely fair. But it's still a choice, because I can choose to go to treatment. I can choose to go to an AA or an NA meeting. I can choose to go to a smart recovery meeting. I can choose to go to the psychiatrist and maybe get naltrexone or Vivitrol or something, anything to help. I can choose. I have to choose to do these things every day. I have to choose to, once I get involved, then I have to choose to do the work. And not only learn about the work, but apply the work outside of the rooms. And this is where we come in as counselors. One of my overarching themes in my counseling practice is practical application of 12-step knowledge, right? Of any of this knowledge. I use the SMART recovery. I'll get into that in a second, but it's practical application. Things you're learning in treatment. Things, if you want to make a plan and without any of that, great, this is your life. Let's make your plan, but let's come up together with the solution that you're going to do. And it's still a series of choices. So both have merit. And on that, well, I'll get to this in a second. So many of you noted in your smart recovery papers about the chat, right? I'm sorry, I got a little dog. If I don't go let him out, he's gonna just bark and bark and bark. So many of you noted in your chat about sorry, I can't see this. What happens when I try to do more than one thing? You noted in your papers about the chats and the differences in 12-step work where they don't allow crosstalk, right? And any of us that have come up in a 12-step program feel like that's just rude and it's disrespectful and it's all the things. That's sorry, I gotta wait here by the door because they're just gonna bark when they want to come in. And it's really it's this is where it comes down to personal choice and personal experience here, because come on, Annette, let's go. All right, well, he's not coming in, so give me a second here. Anyway, so, some people may love that. And some of you thought, and some of you did actually think it was really helpful and really good. And there was some good things happening. Others were like, nah, it's not my jam. It's too disrespectful and too chaotic, right? And so I'm reminded of when I worked in treatment. And I worked in treatment for about 8.5 years at a center. And I'm just going to pop a seat here till they're ready. And in this center, right, I worked in the IOP at the end for several years. And I remember Mondays were chaotic, right? People would come rushing in and there's always whatever chaotic event, Thursday, Friday, Saturday, and Sunday. And they'd want to talk about it on Monday. And two people came in, and one was just going on and on about how terrible this meeting they attended was. People were on their phones. People were getting up and running around. Like, it was just very disrespectful in their opinion, a lot of crosstalk, all the things, right? Another person came in and was like, hey, man, I just went to the best meeting I ever attended. It was very lax. People weren't tripping over the phones. I was able to move around without it being a problem. They were at the same place, right? Legitimately. And so that's, we don't, everybody feels different about that. But this is where, if we're 12-step folks, or if we're not, we can't let our personal opinion there influence what we want our clients to do, right? Because it's real easy to say, no, crosstalk's chaotic for me, so I don't like it. But this is where we educate our people on, hey, this is the philosophy of their program. This is how this works, right? Come on, Mel. This is how that works, right? So we do that. Sorry, man, I got to get this dog. Come on, Midnight, let's go. And anyway, there he is, all the way out there. Come on, bud. So anyways, sorry, guys. I don't want to pause this. I'm going to keep going. But yeah, so it's very different for everybody, the difference in crosstalk versus not crosstalk, right? And that can be with any of these things. Some meetings have timers, as some of you experience, and some are for that, some are against that. Let me get my notes here. Yeah, so... so anyways, they're very different. And also I want you to be mindful of the difference sorry here. Not the difference. I'm sorry. I'm going to sit down and do this thing right now. So remember, counseling support group, counseling and these support groups, they're not for everyone, right? As much as we might think they are and everybody could benefit. I'll tell you, every client I work with an SUD, I always recommend a support group of some kind, always, without fail. Whether they do it or not, it's up to them, right? But I think there's great value in that. That doesn't mean, however, they can't do it without one. If they have an actual substance use disorder, it's the numbers are not in their favor, let's say, but that doesn't mean they can't do it. And that doesn't mean I give up on them because they don't want to go to a support group. Right? And my job is to be educated on these support groups, which you are, and continue to getting more and more educated. And this is why I encourage you to go to many support groups, even outside of these assignments. These assignments are just the surface, right? But you should all know about Al-Anon, Smart Family and Friends, Nar-Anon, NACA, AAA, NBA, all of them. I'm kidding about the last two, but one of you talked about counselors being afraid to talk about addictive behaviors and fear of losing clients. So we don't bring up, maybe we don't press on support groups or not. Don't ever be afraid to lose a client. Do what you clinically feel is best for that client. Again, our job isn't to choose. So this is a very real thing that happens. Now, I'm not in fear of losing a client. They'll either come back or they won't. But I have a lot that don't come back once we start getting to that place of, okay, it's getting serious. Let's talk about treatment options. Many will get right to that place. I have many go do assessments even, and then they never come back to me. A year later, they'll call me. That happens a lot, right? Or when you get to that real heavy conversation, okay, man, look, what we're doing is not working. And they recognize that, but they're not ready to take that step. That happens a lot. I don't stop encouraging, what I feel is the best support for them. So I would also encourage you to visit multiple groups before making a decision on your opinion, really forming an opinion, because you could go to the same group at 3 different times and have 3 different experiences, even though it's the same group. So, look, I've been to a million meetings in my lifetime, and 900,000 of them were wonderful, 100,000 of them less than wonderful. That doesn't mean they don't have value, and this is where we come in with a clinical perspective of encouragement for our clients and reframing thoughts, CBT work, motivational interviewing, and saying, well, pointing out that, yeah, there's value in even the meetings that aren't wonderful in topic or content or personalities, for example. They still have great value in that they're teach me discipline. When I do something I don't want to do, that just builds up self-esteem that I can do these things, right? And if I do these things on a consistent basis, I begin to build habit. Right? That's where we come from clinically. So lastly, in these 2 programs, I want to talk about faith. Many of you noted that. Many of you are people of faith, and many of you are not. Both are great. Smart Recovery doesn't use faith. They use CBT, and again, it's cognitive behavioral therapy, and it's self-management. They're not against, be clear here, they are not against spirituality in any way, or religion in any way, or higher powers in any way. In fact, in their training, they tell their facilitators to encourage use of anybody who has these things, right? Make use of them. You just don't need it to do this work. Right? Because this work is I'm reframing my thinking. I'm challenging my own thinking. Only I can do that, right? So here's what leads me into this. Both of these programs work well together. Now, if you ask people in SMART, some of you noted you heard people saying, well, hey, it's not for me. It didn't work. Great. That's fair. You go to AA, you'll hear people say, well, again, rarely have we seen somebody fail that does it this way, right? You don't need all these other things. It's not AA. That's fair too. But what if I told you they could work wonderfully together? So for someone like myself, and again, this is unique to each individual. Don't put everybody in a box and say these work together great, because that's not true either. But what if we educate our clients on the value of both? Now, I'm not recommending someone dive into multiple programs at once, but I believe the community aspect serves a wonderful purpose. For many, I believe the spirituality piece or the higher power piece serves a great purpose. For many, it doesn't. However, for those that it doesn't, if we can reframe acronyms to, do you believe in outcomes necessarily? Maybe not higher power, but in outcomes. And if I do this work this way, I have a certain outcome, right? So there's still that, and there's still that community piece. But in the 12-step program, in their book, it says acceptance is the answer to all my problems. I believed that the very first time I heard it. Why? Because I can't change everything in the world. So if I accept it, my life becomes easier. And again, this is where we navigate clinical experience and 12-step models merging. In that I talk with my clients all the time about, well, acceptance doesn't necessarily equate approval. Many of us equate acceptance with approval. If I accept it's happening, then that means I approve of it. That's not true. What if someone cuts me off on the road? I will never approve of that. Like, use your blinker. Don't be a jerk. Drive regular. Right? But I'm getting angry thinking about it. That irritates me, man. Just use your blinker. It's not that serious. We're all trying to get where we're going, right? But I have 2 options in that moment. Get angry and stay angry. And that doesn't help anybody. Doesn't hurt anybody but me. That person doesn't care. The deed's done. Now they got me twice if I stay angry. Or I can practice acceptance. And that's how people drive sometimes. And that's out of my control. I'm grateful nothing happened. I'm grateful I was aware. I'm grateful I did my part. 12-step model in action. Right? But I practice acceptance. It doesn't mean I'm cool with it. Like, I encourage it. I'm approving of it. Never will I approve of that. Always use your blinker. That's how you know where we're going. Side note, my brother-in-law one time, and I got in this heated conversation, he said, sometimes you just don't have time to use a blinker. I'm like, bro, that's how long it takes. Like, are you kidding me? Then perhaps you don't have time to get over. Just a side note there. But anyways, my point is, I have to practice acceptance. So this is where we bring in our CBT work, right? Our reframing of our thinking. So the inner smart recovery, right? When I got in and I heard that Acceptance is the answer to all my problems. Well, fast track me here. That's the solution. That's where I want to get. And they just said, oh, keep coming back. Keep coming back. They weren't wrong. Eventually, I put two and two together and had enough experiences to form my own theories and ideals. But Smart Recovery uses CBT work, which provides you concrete tools to challenge thinking, like cognitive restructuring, the ABCs, many of you noted, the CBA, many of you noted, the change plan worksheet, many of you noted. Those things are meant to put me in a place of acceptance. The two work wonderful together, to be honest. But people do what people do, and they bash each other's programs because it wasn't for them. And I'm going to encourage you all to refrain from any of that. Again, don't let my personal opinion get in the way of a good clinical session. Right? So, yeah, I hope you guys enjoyed Smart Recovery. Again, I think all these programs are wonderful. Lastly, on Smart Recovery, I noted this in many of your papers. They have a training they offer, and there's a discount for students. I took it many years ago, and I think I paid $50, and it was worth every penny. You can become a Smart Recovery facilitator if that's something you choose to do, which one makes you more marketable anywhere, right? Just FYI, a little marketing tip there. But two, I never wanted to facilitate a group. I just wanted a more in-depth understanding of the program, right? Because you hear certain things in the meetings, but I wanted to know. And their training is phenomenal. All it is, it reinforces my CBT work as a therapist. Who doesn't want that? As a counselor, it's a solid training. I would encourage all of you to consider taking it. Whether you ever want to lead a group or not, it's just going to help you with CBT work anyway. And motivational interviewing. So that said, coming up, we're cruising through this thing pretty quick. Week 11, you have a DB6, one of your last two DBs actually, and then it's on. I'm sorry, you have. Wait, where am I at? I'm looking at two different things here. Okay, week 10, you have chapter 6, quiz 3. We'll be in chapter 6 for 2 weeks. You have a quiz 3 on group versus individual counseling, and then chapter 6, still ethical guidelines in group counseling, and I'm sure they're referring to in a treatment setting. Then you have your last outside meeting to attend for this class, and you can choose between Celebrate Recovery, which is a Christian 12-step program, or you can choose Refuge Recovery or Recovery Dharma, which are two programs based on Buddhism principles. All of them are phenomenal. I'm not going to get into too much of those. As we get a little closer, I'll do a video kind of introducing you to those. And then we'll do a wrap up at the end, comparing all three of them one last time. But then we go on to, once that's done in your DB, then we do implementing strategies to facilitate strong therapeutic alliance, which is a great chapter in your last quiz. Then we wrap this up with a bow, so to speak, on week 15 with the chapter 5 on matching clients to self-help groups, which is all we've been talking about this whole semester. So we're cruising through this really quickly. I hope this has been helpful. I know this is a longer video. I never do videos this long, but there was a lot to cover from your papers, and I just wanted to really give you some insights into the differences and the similarities into these two programs and how they can potentially work well together. Guys, I think you're doing a great job as always. If I can be of any help, please don't hesitate to reach out. I'm happy to meet with you via Zoom. If I've asked you to meet with me via Zoom, please do so, because I mean, I'm not going to make you, obviously. I can't do that. But I'm only trying to help you make corrections so you don't lose points on your last papers and those kinds of things. Yeah, follow the instructions. If I can help, reach out. We'll talk soon.